Okay, thank you, everyone. So we'll just get started here. So good afternoon. I am Nigmendra Narain, President of UWOFA, and I thank you all for your attendance to our first of two UWOFA talks on Step 3 adherence. Today we have two panelists, Dr. Lauren Cipriano and Dr. Greg Gloor, to speak to the science for Step 3 adherence. I begin with UWOFA's land acknowledgement. The campus of the University of Western Ontario is situated on the traditional territories of the Anishinaabe, Haudenosaunee, Lenape, and Arawadaran peoples, who have long-standing relationships to this land and place. This land is also connected to the Sombra-London Township Treaties of 1796 and the Dish with One Spoon Covenant, Wampum. UWOFA considers that acknowledging territory shows recognition and respect for Indigenous peoples' unique rights, which is an essential step towards establishing healthy reciprocal relations necessary to achieving equity. And our speakers today are first, Dr. Greg Gloor, who is Professor and Chair of Biochemistry at Western and Director of the GloorLab, and an expert on bioinformatics of complex microbial systems. Our second speaker is Dr. Lauren Cipriano, who is a member of the Ontario Science Table and is an associate professor in management science at the Ivey Business School and Department of Epidemiology and Biostatistics in the Schulich School of Medicine and Dentistry at Western, and holds the Canada Research Chair in Healthcare Analytics. We will begin with Dr. Gloor, then Dr. Cipriano. Dr. Gloor, please go ahead and start us off.
Well, actually, Lauren and I decided that she'd go first.
We'll do that then.
My apologies.
No worries.
Yeah. So thank you very much for having us, and thank you all for attending. I think Greg and I talked, and we're going to try and leave most of this time for Q&A so that people get their questions answered. I think for me, the work that I've been doing with Dr. Hedera, who's the Chief of Critical Care at London Health Sciences Centre and the Chair of Critical Care here at Western, throughout the pandemic, has helped inform decision makers at the hospital and in our region throughout the pandemic make operational decisions in their organization, sometimes without the ability to influence what those decisions are going to be around them, but how then to execute on operations conditional on those. And I think we're in that situation now, only we've also had the ability to make some of those decisions within our own organization. At the regional level, our analysis says that we need to be moving from Step 3 into something that looks more like Step 2 if we want regionally for our children to stay in school, which is really the essential priority right now. And throughout the pandemic, our analysis has indicated that the earlier we take moderate steps, the more we can avoid really harsh, dramatic, and draconian steps later. This was really an opportunity for us this fall as a larger community to do something proactive that would result in a different outcome than we saw last December and last November. And right now we're not headed in a more proactive direction. We're headed on the exact same road. The university's decisions have made that harder. And instead of trying to participate in a community-wide effort to reduce contacts and move us towards not repeating the same mistakes we made last fall, we're now contributing to a situation where we're making that happen. And instead of being in Step 3, we're in this Step 3 modified, where for some reason the university doesn't have the same rules applied to them as other organizations in our community. That said, the probability of transmission in classrooms is a low likelihood. Classrooms are very orderly environments. And once we move to late October and everyone of our students is vaccinated and everybody's wearing masks in a classroom with a faculty member there to correct them on the position of their mask and the social pressure from their classmates to keep those masks up and in the right position, hopefully we'll have safe environments in classrooms. But we know that our classrooms are only a small fraction of the activities on campus. And so we're going to see masks coming off and higher modes of transmission in study spaces, in eateries, in hallways. Many of our hallways have terrible ventilation, and they're crowded. It's going to be on and off campus housing. It's going to be gyms and athletics, and it's going to be the social events organized by the university, like the concerts hosted this past week. And so as long as the university is making this not just about being in our classrooms, which are orderly environments, but also about the entire campus experience and the student experience that we're excited about here at Western, then many aspects of that student experience are going to be high transmission, risky activities. And I think that part of the concern comes from the inconsistency in messaging. What we know in health information and health dissemination is that consistent messaging is really important. And I think it is not going to be clear, really it's not clear to many of us, but it's not clear as much to our students that a study room in Weldon with 5 people in it who know each other is going to feel like a safer environment than a classroom with 400 where everybody's wearing masks. And people are going to take their masks off when they know each other. And so consistent messaging is really important in public health. And now we've set up a situation where our students are less likely to understand what a safe environment is and a risky environment because we've told them they can give up one of the pillars of public health, which is physical distance. And I think that that's what concerns me. And I think from my conversations with Greg, him as well. So I'll pass to Greg for some opening remarks, but then I think we'll open to questions.
Thanks, Lauren. I always feel bad following Lauren because she's so clear and concise and very direct. But honestly, I think we have to keep in mind too that at some point we have to exit from our current situation, and COVID will become an endemic, and it's really just how we get there that's important. And how we get there has to be as safe as possible. Honestly, it does involve full vaccination and reopening our society. And other countries are already moving that way, such as Denmark. I was speaking with somebody in Denmark a week ago, and they're ecstatic, but at the same time, they're cautious. They're maintaining many of the pillars that Lauren mentioned. So they're not going completely open, no masks, no distancing, but they are opening as much as they can. And really, we're going to have to learn to tolerate more risk, tolerate some risk. But the issue is keeping those cases non-critical. And I think one of the things that is, and Lauren touched on this, is open and honest information, and we're just not getting that. I don't know how many of you went to the town hall this morning and had the BS numbers that Sarah gave us about 99% vaccination rates, closely followed up by an email from our dean's office saying that people need to actually submit their vaccination status. So, we don't know what the numbers are, and I've asked, but we don't get it. And so I just have a few talking points that I really want people to keep in mind, and remember that it's airborne, right? That's the major threat. Surfaces are a minor issue, and surface cleaning is kind of theater, shall we say. Air exchange, I think Western's doing a good job on air exchange, at least what we've been told, although they're not monitoring. And I think that we should monitor, load test, shall we say, some of the classrooms. Masks, there's questions already in the chat about masks. My preference is not to use one of these, but to use an N95 or a KN95 mask. Even a poorly fitting one is way better than a medical mask, and in turn, that's way better than a cloth mask. So if you can get by with a KN95 mask, it will give you about 5 times the protection, even if it's not fitted. In terms of risk management, if you're fully vaxxed, the reduction of risk is about 20-fold compared to non-vax people for bad outcomes, and it reduces risk of transmission. And so really the point of vaccination is to protect you, but also to protect everybody around you, because it's like a firewall for transmission. And that's really the role of the vaccination of vaccination. And then the distancing, this is, why did we get an exemption? And then the other one is testing and monitoring. And I think that Western is doing the bare minimum here. They should be doing. We should be. There are all these rapid point of care tests sitting in warehouses that are just not being used. And if they're going to open up universities, why cannot these be used to monitor background levels of infection in the population? It's not diagnostic, but then you get an idea of how many people are actually infected. And we see some questions in the chat about that as well. So that's all I have to say. And I think Lauren and I thought that we would just handle questions from people as best we can. So.
Could I just ask if Lauren, given the research of yours that we sent around today, I was just wondering if you could speak a little bit more just to the last point that Greg was raising and very concerned about, as are many of us, on this question of the necessity of social distancing, which the exemption is specifically for that, to allow for packed classrooms. So I don't know if you might have a second to just speak to that, because I think that's a very important point in what you've raised.
Yeah, so I think that scientifically, the extra benefit that you get specifically by standing more than 2 meters or sitting more than 2 meters from another person, separated from the benefit that you're going to get from masking, is, I don't know that is a scientific question that's been answered. In our model-based analyses, we would assume a mask contact at more than 2 meters to be not a contact. That's a very safe environment. That's not to discount what Greg said. COVID is borderline aerosol, and so it can travel, but it's much harder for it to travel when everybody's wearing a mask in the first place, right? So with masks and 2 meter distancing, I would call that not a contact. But then when we start to get rid of that distance, especially with masks that have big open pockets on the side, like the ones that are being distributed, and with very real world mask wearing use. So our students are not trained like healthcare professionals in their mask wearing by any means. And so loose fitting masks, masks that are being pulled down over their noses, masks that are being taken on and off constantly. Now you're starting to lose much of the benefit of masks, and then you need to start relying on the benefit that comes from distance.
Yeah, I think the sort of the rule of thumb is if you wear glasses and your glasses fog with a mask, the mask isn't really doing anything. It's just the air is going in and out around it. So if it's not adjusted so that your glasses don't fog, then you may as well not be wearing a mask, and neither. And so I think that's one of the real reasons for this kind of a mask is the N95 type mask, is that they do fit substantially tighter by default. And you can easily see that there's a lot better filtration.
And you're wearing your mask properly when your air is going through the masks, not out the sides and not out the top. And so that filtration right through the mask means that you're wearing that mask quite tight. And for many of us, wearing something right around our ears is not a tight fit. And so for women who can wear a ponytail, tying that around their ponytail and using those clips that we saw healthcare workers using early in the pandemic to hold their masks on, anything that's going to make sure that you're getting a very tight seal on your face with a mask is going to make a difference for your mask wearing.
Great, thank you. So if it's okay, or Greg, did you have another comment? And I can.
No, I think that's
okay. Perfect. So we can go ahead and raise hands to ask questions, but since a number of people have already put questions in the chat, I'll just select from those, which so a question was asked, and just to clarify, this session is being recorded. We will post it on the UWOFA website, as there were a number of people who are unable to attend, or if you'd like your colleagues to listen to this, we really need to and get the word out of our distinguished speakers as well. So if you prefer to put it in the chat because you do not want to be recorded, that's perfectly fine. But if you are okay with being recorded, you can raise your hand and we can go from there. So the first question I'll start off with is a question that was posed. What if someone is sitting shoulder to shoulder next to an unvaccinated person for 15 hours a week? Is that safe with masks?
So my understanding of the public health guidelines for contact in the hospital setting, where there's quite a bit of contact between infected persons and uninfected persons, is if an individual, the susceptible individual is unvaccinated, that exposure, even with a mask, is considered an exposure, and the person is asked to monitor symptoms and quarantine until their test results can come back. But that if the person is vaccinated, that's not considered a risky contact, and they're not asked to take any time off work to quarantine or to test. The difference between a healthcare environment and us must be noted, though. In a healthcare environment, the individual wearing that mask on the susceptible side is trained and practiced at their mask wearing, and our students are not.
Great. Thank you. Greg, did you have any thoughts on that?
No, I mean, Lauren knows this stuff by heart. So this is in her wheelhouse. So,
right. So another question that was asked was, how is that unvaccinated person even on campus given our vaccine mandate? Well, that's that I don't think is answerable in this case. That's more the question of the protocols that we have, which I would recommend folks to read through the policy in particular for that. I would like to move to the next question. At this rate, is it feasible to think that we could be fully remote, minus the labs, et cetera, that need to be in person by Thanksgiving, given what we're talking about in terms of social distancing and spread?
At a larger community level, if we don't see, so the health unit has also made a call out to major employers in our area to increase as much as possible their work from home policies. The university is not participating in that, to my knowledge, but other large employers are continuing a lot of work from home. And if we see that, if we see a commitment to work from home, we're going to also need to see policies come into place where we see some reductions in indoor dining, reductions in the capacity for non-essential retail, so that we can start to see the reductions in our contacts. We too need to be engaged in less contacts in our social lives and, where possible, in our public and professional lives. But many of us don't control those. Those are often controlled by our employers, as they are for us in this environment. And so we do need policies to be put in place. If we don't see any more of that, if we see this sort of status quo run, then I think we will be looking at increasing regulation being imposed in the second half of October, and looking at more severe measures in early November.
So I want to ask, this is a question I want to ask Lauren to follow up on this. So, like, if we think about it in terms of vaccination mandates and vaccination rates, the most dangerous day is today, and every subsequent day we have more people vaccinated and we have more protection. And so we have this decreasing scale of risk based upon vaccine coverage. And in theory, if we do achieve, say, 98% vaccination by October 22nd, which it would be nice if they would actually release all the numbers and be honest about it. You know, that's basically, I've heard it said by senior administration that, you know, that would make Western the safest place on earth to be in the case of COVID, if we actually achieve 98% vaccine coverage or what, you know, some number. So do you want to, could you comment on that? Because I know we've had conversations about this in the past.
So there's an exchange here. University students have higher than average contacts than other 18 to 24-year-olds. And so when we think about how much vaccine coverage you need in any specific population, you also need to think about how many contacts that population has. And so to even balance out with the normal kinds of contacts that Greg or I might have in our everyday lives, the university students need a higher vaccination rate to even bring them to the same level of risk of infection as we would have. It is true. So in my modeling, when I just look at the prevalence, the projected prevalence that would happen in the university population versus the city, early on in September and early October, the university students have a higher prevalence than the general population because of that very high contact rate, specifically the high contact rate that we're going to see here in September with the types of social activities they engage in. And so they are more risky than a random contact in the general population. But as we move into the university students reaching universal vaccination, and if we don't see any other changes in the general population in terms of contact reduction, we see those cases really rising in our community, then there will be a time where it is safer to be on campus than to have a random contact in London. But that'll be a situation where you can see our entire city is running towards another stay-at-home order. And in Ontario, that we're running towards a stay-at-home order. As if the city is taking some steps now towards step 2, and if we as a province are taking some steps towards step 2, then it is not true that Western will be safer than being in the general community. It depends on those contact choices, though. So there are scenarios where Western would be safer, but those would only be scenarios where it is you're seeing sort of raging community transmission outside of campus.
So that leads us to a question that that one of the persons posed. I'm just going to jump to this question. One is related to the question of how much students reduced their average contact number last year. Do we have numbers on that or estimates on that? But also in the flip side, given that we just saw that there are parties going up and down the 401, and our own university put out a statement saying that students need to stop partying so that we can, or stop basically, doing what students do so that we can not jeopardize the school year. Do you have any thoughts on compared to say last year, or the implications of what we're seeing right now, which is going to probably take off a little bit more in the next days as we get into the weekend? So just thoughts or comments on that?
So one of the things we did last year was that a lot of our, in particular, upper year students didn't return to London. So we had, because we had so many online classes and we had access to online classes for students, even students that had some in-person classes chose to live at home wherever that was and commute to London for a very small number of online classes. They might have only been coming here for an hour a week. And as a result, we really had a much lower, we didn't just have lower contacts for those students, but because we brought fewer students into the community, there were sort of fewer total contacts overall. The students, when we saw what they brought back with them in February when they rejoined us, we also saw a dramatic trajectory change in the role of alpha in our community from that student return, because we had this much higher prevalence of alpha in the Toronto area. The students moved to London, and we saw us equalize very quickly with the Toronto levels of alpha. We're going to see that type of thing again. Right now, it's not going to be about them moving variant, but it's going to be about them moving prevalence into our community.
Great. Thank you.
I think it's actually really disingenuous to blame the students at this point for that. I mean, that message from the president, I think, was beyond the pale in terms of, the messaging is come indoors, you're fine. Party outdoors, you're not. And, the cognitive dissonance is breathtaking. And I'm going to trademark that because it's insane. So that message, I think, is you're either safe or you're not. And if you're safe indoors, you got to be safe outdoors.
Yep. Thanks. And thanks for saying it very clearly what the issue is, right? And I think this needs to be unequivocal in the way that they're trying to sort of disjuncture being in the classroom with 700 people is safer than being outside with 50 people. And neither of these two things are safe for good reasons. A direct question that came through was, is there a mandate to wear masks? We've been given by the university, or a 3-ply reusable cloth mask adequate? A person mentioned they've been getting mixed messages on this. So perhaps Greg, since you spoke about the masks, might want to lead off on that.
I think you just want to get the best mask you can, honestly. And if the best mask that you have available is the non-medical mask, that's better than a cloth mask. If you can source an N95 or a KN95 mask, and you can comfortably lecture with that, I would strongly recommend it. And in fact, we bought several cases of them for our lecturers in our department. And I know that other departments have done the same, and I think that that's far better than what's been distributed. But in turn, those are far better than a cloth mask. And it all comes down to the airflow, as Lauren said. If you can visibly see that the mask is behaving like a bellows, then the air is passing through the mask. If your mask is on and you're breathing and the mask isn't moving, you're not wearing a mask. You just got a face covering on.
Very good point. I like that imagery of the bellow. So on hot pursuit, unless Lauren, you had a comment?
I put a link in the chat. So one of my colleagues, Dr. Eva Enns at the University of Minnesota, has made a Google Doc reviewing some masks for kids and sharing one of her engineering colleagues' reviews of masks for kids. And I know many of our colleagues are worried about their kids' protection in school as well. And so I just put that there as a resource for people who are interested in looking at high quality masks, both for themselves, but this particular document is really about high quality masks for young kids.
Great, thanks very much, Lauren. I do want a hot pursuit on the question that was posed about masks. Member asked, is there evidence that the plexiglass shields the university has placed in front of the classroom for instructors to stand behind the lecturing without a mask are helpful? Will they prevent, sorry, I missed there was another part of that was basically, will they prevent the spread of it as they think, given that it's airborne? And then the other question they had was that, is lecturing behind this plexiglass mask, without a mask unto itself a safe thing to do?
I would not take my mask off in a classroom.
No, absolutely not.
I think you should put your mask on in your car before you get out of your car in the morning, and then take your mask off when you get back in your car, essentially. I mean, Greg's sitting in his office without his mask, but he has a private office. And so those would be the exceptions. In almost every other environment on campus, I would be keeping my mask on at all times. And rooms with engineered airflow, you need to know where the airflow is going to know that a large plexiglass barrier is not going to form an eddy of air in front of you.
Yeah, very good point.
So, unless they've explicitly modeled the airflow in the room, those plexiglass shields could actually be worse than nothing, or they could be fantastic. They could be worth nothing. I mean, the whole plexiglass shield issue came up because early on it was thought that COVID was passed by large droplets that spewed from your mouth, and that's not typically the case. It's typically aerosols. There was a very well done review article in Science magazine about 2 or 3 weeks ago that very clearly laid out the evidence for aerosol transmission of quite a number of highly infectious viruses, including COVID. The plexiglass barriers are nothing but safety theater.
Okay. And that's, I think, another point just to underline what Lauren said at the very start. Once you get out of your car to the time you get back into your car, or unless you're in an isolated room or your own office room, keep your mask on as much as you can. So
there was a question in the chat about recirculating air through the buildings in private offices. And a long time ago, I did an experiment using a technology called PCR, which some of you might be familiar with. And we traced the contamination in PCR. We had an air stack that went up and then an air intake 100 feet away that was coming back in, and we had DNA contamination that was going through that cycle. So it's technically possible that even private offices, there is some COVID virus floating around. The question is it at a threshold that's high enough for a vaccinated person in reasonable health to actually get an infection? And so probably not, but if you're really concerned or in very poor health, even in a private office, it would probably be wise to wear at least the 3-layer the non-medical mask.
Just to hop on that, somebody asked the question, I apologize, I do not know what this is, so I apologize if I misstated, but someone asked, what about using elastomeric masks?
So those are like the ones that, if I understand it, like the ones that people use for painting and so on. Or those are, if you can get N95 or N99 filters for those. Those can be exceptionally good They fit great around the face. They're very heavy. They're very heavy. And they're also very, very hot.
Great. So that's an interesting thing to note. So for those of you that are interested, you can do that, except with the caveats, it's probably going to get hot in there. The next question I just wanted to continue on with was Greg's, your point about the HVAC. So one question that was asked was, what your thoughts on what sort of load testing of air quality UWOFA should lobby for? Should we be looking for CO2 monitors in full rooms or something else?
Yeah, I mean, I think the standard is if the level of CO2 is over about 800, it's a good proxy for the amount of COVID that could be circulating if there wasn't infected people in the room. And the standard is usually something around 800 parts per million, which is about double the usual CO2 levels. There's a CO2 COVID there's a great long Twitter feed about that has lots of information. But it's our HVAC systems that are, as they're described by the administration, is well over the air exchange limits that should maintain lower than 800 parts per million, but they have not load tested. And as Lauren said about the eddies as well, it's very possible that those shields, that behind a shield, there could be an eddy that captures, and that would, the levels in one area of a room could be much higher than another area. So I would like to see the administration do load testing in a room that has 800 people in at the end of every class, for example, would be nice, just to know if we actually are meeting our ventilation standards, and if we are, great. But again, it all comes down to transparency and openness, and they're not doing that particularly well.
Okay. There was another very specific question, and that was, does it make sense to limit elevator occupancy to just 2 people space? In that space, might 4 or 6 people be okay?
So there was a research study done at Berkeley around elevator transmission and even brief encounters. We know, so early on in the pandemic, we talked about people being within 2 meters in 15 minutes. We have quickly learned that much less than 15 minutes can result in transmission. And there are studies of in prison settings where jail guards had less than 2 minutes, but successive exposures over the day to different people who had COVID that added up to more than 15 minutes and were ultimately positive. So we know that even shorter but close contact with an infected individual can result in transmission. And we know that the Delta variant is worse than all of the stuff I just cited, because it's all older and pre-alpha variant even. And so I would not be getting in an elevator with another person. And if I needed to, I would certainly keep my mask on and use as much distance as possible. But whenever possible, I would travel solo in an elevator.
Thank you. Good. So another question related similarly to certain specific things we do. What are some precautions that you would recommend that we should ask students and ourselves to take in relation to eating on campus?
Our eating areas are not exempt from any sort of physical distancing guidelines. And so ourselves and our students should be eating at 2 meter distance. We are all safer if we're going to take off our masks outside. And so I would encourage faculty to eat outside if they're going to be eating in groups. And many of us have the privilege of private offices. And so that gives us a place to eat without our masks that is safer than some of the alternatives our students have. Our students, I would encourage them to eat outside, and that allows them the benefit of the breeze. But in indoor environments, certainly 2 meters. But we also know that without masks, 2 meters and aerosol transmission, especially while eating, is going to be risky.
Thanks.
Yep.
So,
agree with that.
yep. So far, those are the questions I have found. I mean, one other question is, what are your top recommendations for what we should do, and what changes should be made at UWO? I don't know if you'd like to weigh in on that currently or come back to it later, but if you don't mind going ahead so people can get those on their minds.
Yeah, I would really like to see, I would really like to see tests, asymptomatic tests, so that we actually know the proportion of people who are carrying COVID onto the campus on a daily basis. And if you knew that 10% of the people on campus had an asymptomatic COVID infection, then getting on an elevator is a very risky proposition with another person. If on the other hand it's 1% or lower, probably not. And so behaviors could be tuned and in real time if we knew the background infection rate. But these kits are available. They're not very expensive. In some cases, I mean, there is a stockpile that's been generated that is just not being distributed. And many universities in the States are doing that. So they have, they know what fraction of people on campus have COVID at any given time, and so they can change their behaviors in real time. That would be a huge increase in our ability to monitor and then to react to the risk on an ongoing basis. But we're basically flying blind, and so we have to take worst case scenarios into account for our behaviors, and that's a terrible way to have to live for long term, in my opinion.
The rapid tests that Greg describes, the challenge with them, they would impose a significant operational challenge that the university has not done any preparation for, because the rapid tests do have a much higher false positive rate. And at a societal level, we worry about false positives with COVID testing because they require people to quarantine for 2 weeks, and they may be most common. We've heard a lot about false positives with the PCR test. That does not indicate that the person has not had COVID. It means that they might not be infectious with COVID anymore. That if you are carrying the virus, it may be dead virus, because we shed the dead virus for a longer period of time. And so our normal language around false positives with a medical test means an accidental diagnosis that was not appropriate to you. In this case, this language around false positive has really been manipulated, and it's almost like a late diagnosis after you're no longer infectious is what they've been classifying as false positive. Our rapid tests are more likely to give us those false positives, and people will be quarantining after the time when they're no longer infectious. That for our students does not impose a very large economic cost. We worry about that maybe at a societal level. I think in our student population, we would be fine if we had a very low bar for asking people to stay home, but we haven't actually planned to deliver them any material. And so we've made it, in fact, the opposite of that. Even our daily screening tool is not set up such that if a student then screens such that they should not come to campus, they then miss out on their lectures for an extended period of time, and we haven't figured out how to encourage them to do that quarantine and miss those lectures by providing them that material in some other way. What we know from prior pandemics like H1N1 on university campuses, that students were twice as likely as faculty to disregard advice to quarantine when provided to them by a medical professional who had diagnosed them with, in that case, H1N1 and influenza. Wow. Because their symptoms were just not that severe, and so they didn't think it was very important to follow that advice. And the consequences of following the advice are borne personally with missed lectures and missed activities. And so students went to lecture, they went to their part-time jobs, and they went to their social activities even after they were advised not to. And so I put a link to a different paper in the chat, but I'll put a link to that paper as well in a few moments. I'll just have to call it up. But I think that unless we have a mechanism by which the students can quarantine at low cost to themselves, where missing class has a low cost because perhaps there's an online alternative, then we're going to end up with a situation where students are going to come to campus even if they have mild symptoms, that they're just going to say no on the questionnaire. And I think that that is what we've asked faculty to do for years. We've asked faculty, it is very difficult to get somebody else to teach your classes for you. We've all taught sick, and we're going to be in that same situation now. Who's going to cover our classes when we're sick? And what are the plans there? And so as some of us are more protected than others in our UWOFA community, certainly thinking about how you can think about the junior faculty in your area group and your limited term colleagues, your limited duties colleagues, making sure that if they've got young kids at home or they themselves start to experience any symptoms, that you'd be the person that would help them out covering a class to try and help them do that quarantine and isolation, I think is an important social service that we can offer each other as a community. And certainly leaders and department chairs like Greg, making sure that they try and coordinate that within their departments so that our most vulnerable pre-tenure and limited term faculty do not feel that they don't have any choices.
Thank you. Those are excellent and amazing points, and very important ones as well. It should, interestingly enough, this morning at the town hall, if I understood this correctly, and feel free if anybody wants to correct me, I believe the vice provost said that if you are sick and you're unable to teach your class, you should cancel the class. That it's not a requirement that you go and from your bed at tape your video lectures or post them, or put someone else in harm's way, because if it's due to any number of reasons in the classroom. So I think that's an important thing to know. But that said, I mean, we all feel a tremendous amount of responsibility to our students. We want them to do well. I was just talking to another colleague who said, I haven't missed one lecture in my entire life, except for one time I was sick. I had a colleague who lost a close family member and still came to do the lecture before they headed out for the funeral in Toronto and stuff like that. And so that responsibility is there. The way to mitigate all that, which I think is coming through very loud and clear, is by enacting the right policies to do that, right? And of course, we're trying to push for the sort of overall mitigation with adherence to step 3. I just wanted to ask another question that I think is important here, and this was put into the chat, and Greg, you've already responded to this, but the administration position has been that open windows, open doors in classrooms are a problem because they create cross ventilation, whereas the rooms are set up to do, I guess, an upswing or horizontal or sort of vertical ventilation. So they're suggesting don't open windows, don't keep doors open, let the room do its ventilation job as well. I was wondering what your thoughts are on that, on the science of that, because neither of the people I think I was engaged with were scientists, neither am I, so.
My room doesn't feel particularly well ventilated with the window closed. I'll just leave it at that. I mean, Lauren knows the building in which I resided most of the time. It would be kind to refer to it as a dumpster fire. That would be the best thing that could possibly happen to it. And there is virtually no ventilation in that building whatsoever. So, I think it's all well and good to say, blanket statements, keep your windows closed. But if you're in a room that has zero airflow, I'm going to open my window. And again, it comes down, for me, it comes down to, I just don't actually trust all the numbers that we're being given. The few, I don't want to say all the numbers, the few numbers that we're being given. I mean, there's a lot of, there is an awful lot of trust me in the messaging that we've got. So I find that very, very frustrating. And it would be very helpful if they would be a much more open and transparent.
And again, we at UWOFA, we have been pushing for a lot more transparency. With ventilation, for example, we have those numbers, but someone asked, do we have the stats so that I can do some number crunching? And that we do not have, because I know that amongst our collegium, we have people like yourselves and others who are experts and who know other experts who can look at the data, crunch the numbers and say, this is what this means, other than, a 5 or a 6 or a 13, which I'm not going to say that I know what those numbers mean, but I think that that whole point of trust is an important aspect of this. I don't have any other questions that are currently listed. Is there, if anybody would like to participate by putting up their hand, or if you have another question or a question of yours that missed in the chat, we'd be happy to take that from you. We're coming up to the hour, but we still have time, and we'd be happy to address any other questions or points folks would like to raise. So if you could just use on the reactions, although I'm pretty sure everybody here knows how to use Zoom until the update kicks in, then you don't know how to use Zoom. But if you go into the reactions, which is that smiley face on the right side, if you've got it shortened or something, then okay. So I see Allison, please go ahead.
Oh, yes. I just wanted some clarity on those testing from Dr. Gloor. Would that mean that every day we would all test ourselves before coming to campus on a daily basis? I was wondering exactly what kind of testing regimen you were talking about there.
So, well, so the way that that it works in some places is that you do a test, but it's that the reporting is anonymous because of the false positive issue that Lauren raised. So if there's zero COVID, there's a known false positive rate, and if as long as the threshold for the positives for the population is below that, at or around that false positive rate, there's really no duty to report, because that's just basically, or that's almost certainly 99% likely to be a false positive. But if the rate goes up to substantially higher than the false positive rate, then at that point you get into the area where it's very likely that positive is actually a diagnostic positive as opposed to a test false positive. And so that's the kind of regime that I was thinking of, is that it's not everybody every day. It's a random, ideally it's a random sample of the population chosen that is representative, so that we can monitor the background rate in the whole population on campus. That way we know, again, if the rate is high, then any behavior is high risk. If the rate is at or around the false positive rate, then any behavior is low risk, and we can act accordingly. But as I said, we're actually flying blind. We have no idea what the background rate is.
Okay.
So
Allison,
I advocated for that's okay. So I advocated for surveillance-based monitoring last year, not just at the university level, but at our community level, and I got nowhere with that. But certainly that is across Ontario and across Canada, we're dealing with a lot of uncertainty in the level of diagnosis that we have in our community, and that is going to get worse. So the small amount of serology studies that have been done in Ontario and in Canada would indicate that prior to a high vaccination rate, that we were diagnosing about 1 in 4. And so every day, if you check the health unit dashboard to see the number of active cases in the community, you can probably multiply that number by 4 to get a sense of the number of active cases in the region, the actual number. But because the vaccine increases the rate of asymptomatic presentation in individuals, and it really is those symptoms that are driving most people to get tested in the first place, that that number goes down, or I project the number is going to go down to about 15% of cases getting diagnosed going forward. That means that our isolation practices are going to be much weaker. And so it is only with some form of active, either surveillance that's going to give us an unbiased prevalence estimate, which we don't have in place right now, or through some other structured testing mechanisms that we will get an idea of what the real case is and proactively be able to isolate people. I put another paper in the chat, but it's gone. It's quite a few chats ago, so I'll put it back in there. David Paultiel from Yale modeled just a university campus. And he attached his spreadsheet as a supplemental material to this Annals of Internal Medicine paper. And so you can go in there, download that spreadsheet. It's very easy to just change the vaccination rate at his campus. His base case estimate was 50%. You can go and move that to 98% on our campus, and see still the levels of infection and transmission he's estimating in a campus community. It is hard. His paper has an unusual thing. The x-axis is the R value after you've already adjusted for what kind of non-pharmaceutical intervention, so contact reduction, that you're going to impose in your community. And so even at a 98% vaccination rate, you have to do at least a 25% contact reduction to keep the number of people in your campus community infected under 5% over a term in his paper. And the way that you can actually do that is through routine testing. And so I'm going to put a link to that paper in there again, but certainly if you go in and download his spreadsheet, you can change that number to 98% vaccine and still see that curve just shoots right up to a very high fraction of your campus community, because members of our campus community have a lot of contacts.
And just to reiterate, we will be posting these links when we put all this together and post it, so that people can get to the articles and read Lauren's wonderful paper as well. So we're going to make sure all that's made available as well. Question was asked about what's UWOFA's advice and so forth like that. We will message that properly, because just even with this morning, the talk that the vice provost and others gave, the ground shifted on a few things. So we're still waiting to hear from different things that are going on, but we'll definitely make sure to put that in. One question that was posed here was, given the information presented, do you have any recommendations for immune suppressed individuals? Like, these would be faculty of ours who are immunocompromised. What sort of recommendations might you give to them for what to do, what not to do?
So I think that for some of our immunocompromised colleagues, they should seek accommodation, and they should rely on UWOFA to help with that accommodation if they don't get a response. It would be my first thing. If the accommodation is not available, or the nature of the immunocompromised, the reason why they're immunocompromised doesn't make them eligible for accommodation, I would say that, and this is different for people with different levels of job protection, I would say. For those of us with job protection, the survey literature said that young people reduce their contacts in an effort to protect their parents and their grandparents. That did not say they're university professors, but I think that we have the ability to humanize ourselves to them. And I think that if necessary, appealing honestly to your students. I'm going to arrive you need to be in your seats before I'll walk down the hallway. So I need you to arrive early and be in your seats so that I can walk down the hallway safely. Ask people not to approach you before class, not to approach you after class. Make yourself available for Zoom office hours, and then and ask people to sit back from you and to respect you as much as possible. By humanizing us to them, that hopefully we get some additional protection that we wouldn't otherwise. For people who feel more vulnerable in that situation, then I would hope that their senior colleagues and their department chairs would find some other ways of creating a moderate accommodation, even if they don't get a formal one.
Yeah, I think that I agree that accommodation is the way to go here, and I think that this is a role that UWOFA could really take should really take a very strong line on. Is that there are people who are immune compromised, and for whatever reason, that they really need to have automatic accommodations and not make this a difficult, lengthy process for them, because ultimately it's people that can't get vaccinated, or if the vaccination does not work for them, that we're trying to protect, honestly.
Good. So just on that, two things. If you are using the toolkit, which is on the faculty relations site, we encourage you to use it. And if you are pursuing it, please connect with our UWOFA professional officer. We're also trying to track how these things are handled and also to prevent discrepancy from one faculty or department to the next. So please, definitely let us know. And even if you're successful, we would appreciate knowing that so that we can say, okay, in this department, this is happening, or in your faculty, we know these accommodations are being made. The other important thing is that they have a single person who has largely been tasked with this, Dirk Vogelsang, and this is in the posting on the faculty relations website. So please do approach Dirk directly if you feel that there is some friction internally to ensure that. We have been provided whatever assurances one can have that these will be dealt with fairly and adequately, and people will not see later repercussions for choosing to apply for the accommodation and stuff like that. But UWOFA is there for its members. So if those things are happening, then please let us know, and then we can start to engage with the things that need to be done in that regard. I had one other question that's actually technical in the same way, and then there's another one that was made in terms of a point which I want to sort of just raise with you, Greg, specifically as well before you have to take off. So maybe I'll pose that one first. This is a comment made in the chat where a member asked, I think that the ventilation data provided by Western is somewhat misleading. I think you've already spoken to that. Issues include that MERV 13 filters do not filter virus particles, and EACH values assume that recirculated air is filtered to remove these particles. I gleaned these conclusions from the links presented by Western. What are your thoughts on that assessment about the MERV 13 filters? They don't really help out with the particles anyways, and just generally what you've seen in terms of what Western's provided us.
Yeah, so I mean, I'm not a ventilation engineer, but again, this is why I think it would be wise to do load testing of the ventilation, of the actual ventilation. The MERV, my understanding is MERV 13 doesn't filter all the virus particles, but it filters a fraction with every cycle through. But again, if you're in a room where you're 10 times over, 10 times the amount of CO2, and there is an occupational health and safety CO2 limit actually as well. I don't know what the number is, but it's not as high as it could be in a completely recycled room. That load testing would actually help alleviate some of these concerns, but we're relying on really theoretical engineering diagrams, and and as far as I know, they've not gone in and done any load testing on any of these rooms.
So I guess I'll pose this technical question to Lauren and directly. Is there any merit to asking students to sit further back from the instructor in the classroom if there's adequate space? Does this help at all, I guess?
Yes, if there's adequate space in your classroom, either because you have lower attendance or happen to be in a larger class, I would certainly recommend that you ask students to sit back from you and to spread out in the room if we can take advantage of physical distancing. This is what most of our Ontario University peers are doing, is that they're operating medium-sized classes in very large classrooms so that they can do classes of 60 or 75 or 100, but they're doing them in spaces that would otherwise seat 250 to 400 students. And so certainly if you've got that privilege in your classroom, certainly taking advantage of it. I did have one more comment that I want to make, because I feel like certainly the president's message starts us on the same path that we saw last year, where where students and their actions are going to be blamed for the situation that we're in. And Greg touched on this earlier, and I think it is an important point that student parties definitely make the situation worse. That is definitely true. When we host the parties, like we did this past week with the concerts on campus, certainly we contribute to that environment. But many of our students are also uncomfortable right now. Many of our students are also not being accommodated right now. And our students' structural contacts in their lives are very different than ours. Our students live in households of 3, 4, 5 other people. Their intimate partners are all in a different household. They work in the service industry. Some of our students are frontline workers. And so when we think of the structural contacts in our students' lives, they are at higher risk of exposure without parties. And then some of them choose on top of that to add some high risk social activities. They're all going to get blamed for those high risk social activities. In many ways, we created this environment that has put our students at higher risk. And so making sure that we recognize many of our students are also uncomfortable right now with the situation that they're in. And many of them have little control over the number of structural contacts that they have in their lives as well.
And to add to that, we add to the structural problem by, say, I teach an NCB 101, and if the class ahead of me with 700 students is exiting and the class that I'm in, 700 students are coming in, that hallway cannot socially distance 1,400 individuals. Even if we take half of them out and say they're both in the same class, which they're not, unlike my psych class that follows with Dr. Mike and stuff like that. Now, even though the university has gone ahead, well, they have suggested that a lot of these large classes are online. Not all of them are, and there's a good number of them. A good number of our classes, they've said, are going to be in person, right, in the in-person experience. But we're creating, as you say, the structural conditions both outside the community by creating these hosting events, as well as individuals just coming onto campus. And I think the big thing that, just to sort of go back to the very opening comments that both you and Greg had, by telling students that it's okay to come back and you can be stuffed into a classroom with 100 to 700 of your peers, then it's only reasonable for them to assume that they can hang out in a party of 50 or 100 outside, right? They're aware of all the same things, these sorts of things as well. A question has come up, and I don't know if, Lauren, you want to share this or not, but the question was asked, does Western Admin know about these ideas and modeling that has been shared with us today?
Yes, the research has been shared with the leadership of the school and is publicly available online. So it's been up on medRxiv now for a week, but I first shared some of our preliminary results with Dr. Shepard early in August. So they've had information for much longer than the public community.
So this would have been prior to the exemption. And I think the exemption is an important point. We're operating in an exemption. We are, as I've said in my tweets, we're a university, not a unicorn, but we're operating like we're a unicorn, not a university, right? So it should be noted that this is part of the exemption that was taken, even though the data was presented to them. At this point, I know, Greg, you have a meeting to get to as well, but are there, so I'm going to thank you, Greg, for that. Are there any other questions? Greg said he can wait a minute, but I think most of us, if you have other questions or comments, as you know, these are our colleagues, so you're more than welcome to email us, or you can email UWOFA directly if you have technical questions about things like, somebody asked about how are unvaccinated people coming onto campus. The issue there is simply there are no building monitors. Some buildings have them, some buildings do not. Some buildings have class monitors, other buildings do not. They're just using spot checks, which means that students have to provide that, but I'm not sure how that works. How do you spot somebody who might not be vax compliant, vax mandate compliant? I mean, these are the things that we just are all the ifs out there, much of which can be redressed with things that Lauren and Greg have brought before us. So at this point, just before we close, I want to take a moment to thank both of our panelists, Dr. Lauren Cipriano and Dr. Greg Gloor, for making themselves available on such short notice and giving us these amazing insights and their analysis as well. Very important for us and much appreciate that. I also want to thank our members who attended and provided questions that were very important for us to get a sense of what our concerns are. And again, when we put together UWOFA messaging, it helps us to know what our colleagues are thinking. And I also want to thank and recognize the work of our UWOFA staff and members who helped put together the first of these 2 UWOFA talks. This has been a labor of love for some of us to try to make sure that we get this, but most importantly, it's been a labor of support to make sure that our members know that UWOFA and their colleagues, as Lauren mentioned, there are those of us who are more situated or less vulnerable positions, and we're speaking out. So very much I want to acknowledge acknowledge those folks, and I want to acknowledge all of our staff for doing all a great job to pull this together. I look forward to seeing you at our next UWOFA Talks on Thursday at 2 p.m. about the law and ethics of Step 3 adherence. So please, everybody, take care and have a safe afternoon. Take care, everyone. Bye-bye.